Thank you, Madam Chair. Always glad to be with y'all and share with y'all the good work going on at the Department of Health. And uh, we'll try to keep things easy for y'all with us this year. First off, some good news. If you remember, 2 years ago, I committed to y'all that you would have an agency run on physically responsible and sound principles. And we have been following through on that, and it is paying nice dividends for the Department of Health, which helps to relieve some of the strain on the state budget. We have closed the $10 million gap that I had shared with y'all 2 years ago, that I had great concern dealing with as we were coming off COVID funds, and we had been able to close that gap through the reorganization process that I had shared with y'all 2 years ago that is well down the road of implementation. And we now have more county health departments open 5 days a week than we have had in a very long time. All of our level twos, which are fully staffed with nurses providing public health care, and all of our level threes, which are our super clinics around the states that are fully staffed, including with the provider every day. They're all open 5 days a week. Many of our level ones in our really small population counties, they're open more than they have been. Many of those are open 5 days a week, not all of them, but we're trying to move all of them to a 5-day-a-week schedule as the economics work. And we've been able to do that without any increased state requirement. So that really has come about by reducing our overhead through the consolidation process, which despite consolidating, our access to public health care is much better than it was 3 years ago. It also is coming about through much better revenue generation. And just our billing is up significantly. Our revenue cycle is doing very well. Very proud of my revenue cycle department, which passed an external evaluation with flying colors. So our revenue is up significantly. The statute that you empowered us with 2 years ago, requiring private insurances to recognize us as public health providers, is now generating about $1 million more a year that previously I had to pay for the care of those patients out of state funds. So as we continue to work through just implementing fiscally sound policies, it is generating a nice return, and we still have more to go. We're not finished. There's still a lot of opportunity for us. I would tell you, now we have more providers at the Department of Health than we've ever had in the history of the agency. We've gone from 12 nurse practitioners when I assumed this post to now we have 34, I believe, and all of these are out in the field seeing patients, and they're seeing more patients and generating more revenue as they see the patients that need to be seen. My expectation is we likely will be up at least to 40 nurse practitioners as we expand our level 3 clinics. I have personally been meeting with every program area that spends a dime of state dollars, and I have been reviewing their budgets personally. If they're using state general funds or healthcare expendable money or tobacco fund money, I am walking through how they're utilizing those funds. And we've been identifying several programs that had fees in place that just had not been adjusted. And, when you haven't adjusted a fee in 10 years, inflation is going to blow right past that. And we had been subsidizing those programs with state general funds. We've been just thoughtfully, methodically getting our fees in alignment so that we can get state general funds out of those programs. They need to be, as much as possible supported by the fees that we generate. And the fee increase that we've been slowly working through the last 2 years has really relieved a lot of pressure from those state dollars. And I remind you those state dollars are precious for us. That's where our discretionary power is. Federal funds are incredibly important, but not a lot of discretionary wiggle room with those funds. So the state funds are critically important. Um, I, I would tell you that we have freed up about $2 million walking through that process, that I'm able to pivot to areas that are not fully funded otherwise. And finally, in terms of good news, when I began this work 2.5 years ago, we were dependent on the federal programs by 80% of our budget. And now, through everything I have shared with you, plus the fact that you have graciously helped us with state funding the last 2 years, we now have reduced that dependency from 80% down to 70%. So that's a combination of us doing better, generating more revenue, getting our fees in better shape, plus the grace that you have shown us the last two sessions. So it's very important. We cannot be that dependent on federal resources. And so it is a big goal of mine that the department itself handle as much of the burden financially as we possibly can, and then, and not be a burden to the state or the counties. And I can tell you that county support is a little unstable. We certainly not going up very much, and in some areas going down. I'm very grateful for our state support. But the challenging news is that we all know that federal cuts have to come, that the federal budget has to be reined in. And I have told my team to anticipate federal cuts probably along the 20% line, and that that flows to us. So the CDC funding, 80% of what Congress funds the CDC flows out to the states. If the CDC takes a 20% cut, that's going to pretty much be a 20% cut down to us. And CDC and HRSA are the two big federal agencies that do most of our funding. So, and I'm fully understand the need for federal cuts, but it's my job to be ready for them. And we're trying to be proactive and not just reactive. And this year, I'm not asking you to backfill those anticipated cuts. I think we're going to be okay this year. We'll see next year, but right now we are okay. I want to thank you publicly for the 2.9 million that you appropriated to us for public health programs, and specifically allowed us the discretion to fund areas of work in the agency that were high priority, where we did not have enough state or federal funds. And I would tell you those areas were maternal, infant, child health, mainly. That was our largest component of that 2.9 million, at about 1.2 million of that. And that funding is going towards the Healthy Moms, Healthy Babies program, the OB system of care, and promotion. Currently, we're having to look at certain level 3 clinics providing perinatal care again, just because of deserts that we're seeing in the state. And I'm needing those resources to staff up in that area. I wouldn't be able to do that had y'all not blessed us with that 2.9 million last year. The syphilis campaign has been extremely effective. I did not have enough money to fight syphilis the way we needed to. This year, it has been an all-out war against syphilis. And the billboards that you have probably seen are raising awareness, have been very effective. And our partnerships with community partners, especially hospitals and our highest impact counties, is really paying dividends, where we have emergency departments partnering with us to vastly increase screening and immediate treatment. And so our test to treat program with syphilis is really bearing fruit, and very, very proud of those results. I would tell you, because of these investments, this year I can give you a return of that investment in human capital Now, it may be too early for me to say, here's the cost savings by investing in public health. I can tell you the savings of human life because our forecasting for syphilis for this year is much better. And I'm waiting on the final 2024 reports, but I'm anticipating a significant reduction in congenital syphilis, which has been aggravating our infant mortality numbers. So those dollars were well spent, well invested strategically, and are bearing fruit in the ways that we need to see. We used about 200,000 for the county health department reorganization. That's bearing financial return already. State health plan I have Dr. Jennifer Golson here who has responsibility over the state health plan office in the Mississippi Center for Rural Health and Population Studies. We're using about 600,000 in that work to rebuild the state health plan. And then emergency medical services, I shared with y'all last year, key priority for the state. And we've invested about 100,000 in raising awareness and promoting the need for EMS workforce. New projects. So, and what I will be asking is not to, I don't need really, well, I would love an increase in that number. Happy to take it if you'll give it. But that with the 2.9, if we can hold that steady, I have the ability to shift from some of, especially the syphilis investment and some of the county health department investment over to a couple of key priorities, and that is obesity, diabetes, and hypertension. And then our K through 12 partnership with the Department of Education for health promotion, because the way we are going to defeat our poor health outcomes is going to be through promoting health for our children K through 12 and helping them know how to just simple behavior choices that will improve their life expectancy, reduce the risk of obesity, diabetes, hypertension. And then also, very importantly, we have to impact the number of children we're losing to accidents. So one thing we're doing right now, working with the Department of Education, we're working to provide them the leading causes of death in each school district in segregating the ages. So, K through fourth grade, middle school, high school, and giving them awareness of here's what's killing the majority of K through 12 age individuals that are, in your care right now. And then I also have to worry about them, not just living long enough to graduate, but then making sure that they're less likely to die at age 38, at age 55, age 63. And that's really going to happen, I think, powerfully through partnership with the Department of Education with K through 12 health promotion. I like to talk about my buckets, and I have those here for you. And the four major buckets, and because our appropriation is interesting, but the first bucket is the core agency appropriations to keep the train running and do the things that we have to do to keep a state agency operational at 24.7 million. The appropriations directed to named agency programs at 22.7. That would include early intervention that we need to talk about, but all of those named programs are in bucket 2. I consider buckets 1 and 2 our core public health work. Bucket 3 are the pass-throughs, which are very, very important, and y'all are doing great good with that money, but those are monies that we administer to flow out to other partners as you see fit. And then the fourth bucket is the trauma fund, and I always want to keep the trauma fund separate in front of you so you see what it is. It is in our appropriation, but this, separately administered and is almost like a program unto itself, like the cannabis program. The cannabis appropriation is separate. I don't report that here, but that's like 7.2 million. Now we have Office of Mississippi Physician Workforce that would be in bucket 2. That's a new assignment for us, and glad to have Dr. Richard Calderon. Richard, wave to everybody. He's the new director with Dr. Mitchell's retirement and Dr. Calderon as our new director of OMPW. My ask is, in bucket one would be level funding. And I can handle the inflationary cost through the results that I shared with you earlier, that we will have the ability to handle the increased cost that just come with inflation and providing health care in our system and also within the agency. In bucket two, the Office of Mississippi Physician Workforce, that core appropriation, we're asking for level funding with that. The main issue that we need help with is with early intervention. We've been working with the early intervention task force that was legislatively ordered, and we are working to implement as many of those recommendations of the task force that we can. To do that, we're going to need to get the maintenance of state effort up. Right now, it runs about 3.6 million, and that we do have to include Senator Hobson, the TK Martin funding. And so with that, it's about 3.6 right now. We really need to get early intervention up to 8 at least. I would really needs to be closer to 10, but if we can get to 8 million, I think we can get an awful lot done with the new model design that we're being asked to do. And here's how I'm asking it. Right now, if you can take the state effort component from the 3.6 and add 2 million to that, I am working through other legislation to access some funding that would be newly discretionary. And I definitely this year, and I would expect I could also do it again next year, that I can match that with 2 million out of that discretionary funding, and that would bring us to 8 million. So if you can raise the state component 2 million, that with what we can contribute, that'll get us to 8 million. Any questions?
I do have one question going back to the county health departments. We had discussed in previous meetings, some of the buildings that were in disrepair. Do you know how many counties that were still not operational, at all? Or are there any counties where we're not operational?
I mean, we have 2 counties that do not have a local health department. That's Issaquah County and Benton counties. And that relates to, Issaquah shares one with Sharkey.
Small county.
Yes, ma'am. We call Sharkey County, we call it Sharkey Issaquah County Health Department. Benton County has not had one probably going back to 2017. And I actually went up to Benton County this year and met with the leadership at the North Mississippi FQHC and that area. They're doing great work. And actually, I think it's more important that we augment what they're doing instead of trying to just open up another.
Absolutely. If the FQHC is handling it, then we need to let them handle it.
That's
We
right.
don't need to duplicate
I agree.
in small areas. I just wanted to make sure.
Yes, ma'am.
The problems that we had before, it sounds like you've got most all of them resolved as far as being open and back functional and having nurses in there. So that is a major accomplishment. And, I'm sorry that we ever, made the moves to dwindle it down like it was, because I could see that the need was still going to be there regardless of what we thought primary care was going to be able to do. So I personally want to thank you for working that hard and trying to get it back functional like it was 20, 30 years ago. So, because we're going to need it. We're always going to need it.
Yes, ma'am. So what we're doing, especially in our smaller counties, is we're looking at the community partners there who need to be leading the way, right. FQHCs, rural health clinics, free clinics, and that we are working in support and not competitively. And there are some counties where that's enough.
Yeah.
And then there's some counties that are low population counties that we're the only thing there. So I don't care how much it costs. I have to have a presence in those counties, but if there's no one else to do the work, and we just absorb that overhead cost. Usually, those are very expensive county health departments, but they're serving a really important role. And we're just working through that. I can tell you the level 2 clinics and the level 3 clinic model is working wonderfully well. And so no more sending staff all over the place, closing here, opening here. It's nice and stable. The workforce is improving. They're happier. Morale is better. And it's more cost effective. And then we're still studying the level 1 clinics for what's best for those communities. The only units that have been closed are small counties that had duplicates. There's some small counties that had 2 county health departments, and there just wasn't enough business for them. We consolidate those down to 1.
Well, that's good. And it sounds like you're doing everything that needs to be done, or in a short amount of time, I might add, from where we were a year ago. Sounds like you've made a lot of progress.
And I want to give great credit to Dr. Renee Dotson, who directs the Center for Public Health Transformation. She and her team have been working really hard on this project, as well as the eligibility determination and enrollment assistance for Medicaid and Marketplace to reduce the burden of uninsured for the county health departments. That generates more revenue for us, and helps the patients wonderfully well. So a lot of good work going on there that is helping improve access to care, public health care access specifically, and then reducing our overhead and generating more revenue, that we turn right around and invest in the county health departments. I told you, Office of Physician Workforce, we're asking for level funding there, but we do have a residual issue that would be in bucket 3 as a pass-through. The $3 million that y'all wanted that y'all had funded to go out to community-based residency programs, that those payments did not occur with the transition, and I just need to work with y'all about what your wishes are. We've not received the money. We don't have the money to disperse. And we're working to, see how y'all want us to deal with that. Those residencies were promised the funding, and they just haven't gotten it yet. And I don't have it in my budget to give it. So we can work, Senator Hobson, with Corbin and work that out. I know y'all's intent was for that money to go out. Madam Chair, the only other issue is the cannabis appropriation. The cannabis program is doing well and maturing well. We generated, with our regulatory work, with our licensure fees and our regulatory fines, we generated $1 million more for the state general fund than the appropriations for both revenue and the cannabis program, the health department combined. So from a regulatory standpoint, the program is actually making money for the state. And with the excise tax and the sales tax on cannabis, that generated another $8 million. So the cannabis program generated about $9 million more in funding to the general fund. And remember, all that flows. We get the appropriation, and all the fines, fees, and taxes go into the general fund. So, and we are fine with the appropriation as it is for yet another year. I just like to remind y'all, the cannabis program is making money, and we do a lot of work to make the cannabis program effective and safe and regulated in a way that I think would be pleasing to y'all. But there are resources there. So bottom line is level funding, except for $2 million for the early intervention project. And again, that's funding for that program specifically. And then the $3 million that we have to work out for the community residencies.
We have some that continue to violate some of those cannabis laws and regulations. I think Representative Wilkes talked to you about
Yes, ma'am.
some of that. We just need to make sure that we follow up on those that are repeat, that are just determined they're not going to do what the law says that they're going to do.
Yes, ma'am. I would
Because we continue to have problems with the same ones
absolutely.
in our area. So
There,
just want-
a physician was excluded from the program this week
Okay. All right. Because
for the things I think you're
I
referencing.
think I got 4.
You need to send them directly.
And social media too. So
Yeah. All those that come to our attention that are in violation of the rules and regs, we intervene. And if they repeat, then they're excluded from the program and we refer to their appropriate licensure board for unprofessional conduct.
I appreciate that because I know they can read.
Yes, ma'am.
Anybody else have any questions for Dr. Edney? Senator Pope?
Thank you, Chairman. Back in another life, 2 or 3 years ago, you and I had conversations regarding the deplorable conditions of some of our health department buildings. And that's supposed to be kept up, as I understand, by local boards of supervisors. Has that improved any?
It has. We still have challenges, but I can tell you we have some counties that have done amazing work in upgrading their facilities. Specifically, Forest County's done an amazing job. We've completed a full renovation in Yazoo County. We're currently have a renovation project going on in Wilkerson County. And the renovation projects typically, especially in the smaller counties, we do a partnership. I'm able to use some federal funding in partnership with local funding to get those units really renovated because we have too many that are not ADA compliant and are not HIPAA compliant, which is a big problem for us. So, and I would say our 2 counties that were in the worst shape have both of those have relocated us to very, very acceptable facilities. And we still have a lot of Hill-Burton era buildings that they're hard to maintain. They're hard for the counties to maintain. I would say the majority of counties are good partners and they really take care of the buildings as best they can. We have some that don't. And then it's across the board in terms of what the local funding is in terms of cutting the grass, paying the utilities. There are some counties that all they can do is just give us a building and then we keep them up as best we can.
Would your assessment be that we let you deal with another year or 2 before the legislature might get involved?
Yes, sir. And there are some other really good projects and it may well be, I think it would be a very good investment of some capital expense funding to help counties upgrade some of these buildings that they just don't have the ability, they just don't have the resources to do. I would remind you, the county health departments are not built into millage. There's no millage assigned to them. The responsibility of the county is to provide us a building. And then the statute encourages them to support the funding, but it's not required.
Turn a little bit. Burn Center was something critical a couple of years ago. Where do we stand on that and how is it working? And are we offering Mississippians good burn care?
Yes, sir. We have, in the state, we have 2 designated burn centers. We don't have a state burn center. We have designated burn centers. And now we have 2 for the first time. So UMC and Baptist and Jackson, both are operational and, we're working with both in terms of they received their designation, but they still have more work to do, and they're doing that work in cooperation with us. A big concern that I have is we have 4 burn centers that are major burn centers outside the state that there are levels of burn that we can't take care of within the state. UMC nor Baptist can handle. So the pediatric cases, the extensive percentage of body surface area burns have to go to places like Memphis and Augusta, Georgia, and Mobile. Their funding has been cut off because of language and statute that says that the burn funds are for designated burn centers in the state. And that is a problem. We cannot afford to lose access to those burn centers because our burn centers refer out to them and they're taking care of Mississippians, and we need to make sure that care continues.
Thank you very much.
Thank you, sir.
Anyone else have a question? Senator Hobson.
Thank you, Madam Chair. I should have brought a pen in here. You've said several things I want to follow back up on, but I know we'll have an opportunity to meet. And I do want to come back to, at some point, having an inventory on the county centers, making sure that we've got a pretty good handle on it, because
Yes, sir.
maybe things that the local legislators may need to speak with their boards about. So
Yes, sir.
getting a good list of that. Second would be trauma care. I'm curious, I see the number down in here that you're requesting on trauma care. I know last year, late in the session, and you and some others from hospitals, we kind of got together and we got the number that absolutely had to get to,
Yes, sir.
but no fluff in it, but making sure we had enough for the trauma care system to work. Do things seem to be on track, or are they falling behind on that? Are we good?
No, that was very helpful. The Corbin was at 6 million, I think, 6 or 8.
We got up to 32. I thought we got up to 32 million total. Those 6 extra.
That was 6 extra
Additional
on top of,
6.
yes, sir. And that was very helpful. And the hospitals received their first increase payment last month. And they'll get another one for state fiscal year in June based off last year's appropriation. I definitely think it needs to be every bit of where it is. But I think, there's opportunities for us to look at the fees that flow into the trauma fund. I mean, we will do whatever y'all need us to do.
Okay, that's a visit. I know Senator Hill, we probably need to have a conversation. The other one, I do want to get as much information as I can on the early intervention we'll need to talk about. And then there was one other area I was thinking that we need to, I want to circle back with Senator Hill and you and your staff on the pregnancy issue of what's going on there.
Yes, sir.
So
I'm very excited. Board of Health approved for us to move full steam ahead with the OB system of care, which will move us light years forward in terms of getting to national standards with our birthing hospitals and basically bringing high-risk perinatal care into our system of care work, just like we do trauma, stroke, and heart attacks. I'm really excited about this work, and that's where a lot of our maternal infant designated money is going to build that system, and that will help high-risk mothers deliver at the right level of care, make sure that high-risk babies are being born at the right level of care with the NICU as much as possible, and when they can't be born there, then to be transferred quickly, which is a challenge right now. So the system of care really looks at that critical window of labor and delivery and immediately postpartum to make sure our moms, and these are mostly Medicaid moms that we're losing, that our moms and babies have the very best chance to survive that critical window. And so that's, once we're fully implemented, we'll be the only state with a comprehensive system of care directed at high-risk perinatal, and we have a lot of national attention on it right now, and I'm real proud of that work.
final question is related to nutritional education, nutritional information for kids. And this came up in our subcommittee meeting this morning with Mississippi State Ag, their extension services and nutrition education. We've got a lot of children that are obese.
Yes, sir.
And there's a lot of type 2 diabetes that's going on, which can be tremendous cost to the state and tremendous health detriment to those individuals. And what are you doing? It's just something we need to be attacking more than we are, I feel like,
Absolutely.
at an early age and through education to help our young people certainly understand the healthy eating habits and ways for them to be healthy the rest of their lives. So what's being done through the Department of Health, and what do you think needs to continue to be done to get that under control?
Well, the most impactful thing is that Dr. Evans and I met 2 weeks ago to really look at what can we do together to impact exactly what you're talking about. And there's two issues to deal with. Number one, we need to teach the just simple behavior choices, which include diet, nutrition, but activity as well, to prevent becoming obese. But then we also have to intervene. If we have an obese second grader that we ignore, we we have condemned that child to a shortened lifespan. An obese second grader is not going to do well without intervention in the ways that you're talking about. That where we have fallen short is with school nurses. We have backed away from the school nurse program. We fund, I think, 54, 56 school nurses for the Department of Education out of the tobacco fund, but we don't have enough school nurses out there that, it's not just the obese second grader, but it's the fourth grader missing in a lot of school because of asthma.
Can I interrupt you real quick
Yes,
on
sir.
the nursing? Because my only experience is through my local school district, and I think they're very good on nursing. So
Well, we lost.
this may be a choice by the different school districts.
It is,
if they need
absolutely.
nursing. But I also think there could be some other things done through, I know this is outside of your arena, educational programs within the schools, but also to the community, the health centers, to make sure that there's access to that information.
Yeah, absolutely. I'm very proud of our nutritional education program through the WIC program. Nutritional education is a big part of WIC. But what you're seeing, Senator, is a lot of school nurses were funded on COVID dollars through the pandemic, and those funds are gone. So districts are having to make choices. I know our local district had to make some choices. And school nurses are really impactful with intervening with health issues of their students, but also with health promotion. And what I'm advocating, and where Dr. Evans and I agree, is not to add more classes, not to add any burden to the teachers, but to incorporate basic health promotion, evidence-based principles into the school day so that students are exposed to those behavior change choices so they can make the right choices. It was very successful with seatbelts in the 90s, very successful with tobacco. Now we're fighting vaping, but tobacco cessation, a lot of that occurred in the schools. And we've got to do the same thing with obesity, diet, nutrition, activity, those things.
I think what a lot of people don't understand is how much, even if you think that's a choice issue, and it is for adults, it is, but for what a lot of people don't realize is how much money we spend at the state level on funding diseases that are easily preventable.
Yes, sir.
We fund and we spend so much money, and the costs are extraordinary. And this can be through education or through some programming. This can be prevented largely.
Yes, sir.
If you work on that. I think what would help us as decision makers on this, on funding and other programs, is data to talk about. I know years ago we had statistics that showed Mississippi had we kept going up on obesity charts and diabetes and hypertension and the things that we know are, all the comorbidities. And at one point, I don't remember when it was, it's been since I've been here in the legislature, we got information that we had maybe started to turn a corner and head back down. But then I think there's been other information, especially related to children, that maybe that's ramped back up. I don't have the data to tell me exactly what it is, but is that something that your office can get to
We already have it. And
help us
yes, sir.
understand, help the public understand what a crisis this is for our state?
Absolutely. Yes, sir.
And it's a thing that can be attacked and helped. We can help tremendously. May not get everyone, but we could certainly change the lives and the trajectory of lives for a lot of kids out there.
That's the whole point of this. Two things. Number one, our annual report generates all that for you.
Yes.
In the annual report, which we just released last month, we'll be issuing our updated health report card for the state, which shows some of that. Obesity, we still have made significant gains. And instead of being 50th, we're now tied for 50th among 5 other states. So Before we owned last place with impunity, and now there's a lot of competition for last place. So that's good for us. But secondly, if we wait for an individual to become an adult to impact their chronic disease risk, we've lost the bet. We have got to help children understand the basics. And to your point, I can tell you the number on what it cost us and for the economy in Mississippi for poor health. Just the 3 leading causes of death: heart disease, cancer, accidents, and then if you include maternal infant death, those 4 causes of death account for $25 billion loss to the economy every year for exactly the things that you're saying. That is a huge part of our gross domestic product that's being eaten alive because of poor health. So the investments we make in these programs, which is why I have obesity, diabetes, hypertension, teed up for our next round of attacks, is because it won't generate for the health department, but it will generate it for the economy. And every time you see us move like we have maternal death, we're not 50th anymore. We're about 44th. That's chipping away at that 25 billion. As we get off the bottom with our babies, that's going to impact that 25 billion. As we reduce the deaths from accidents, I mean, all of this will snowball in a positive way. Right now, it's snowballing against us. So I'm right there with you, sir.
Thank you, Madam Chair.
Dr. Edney, I'm going to address the elephant in the room as far as some of the statistics I've read of across the country where the USDA SNAP program, the #1 purchase product was soft drinks.
Yes.
So I think if maybe the health departments and legislators around the country, I mean, Mississippi gets a ton of SNAP dollars,
Yes, ma'am.
and you're talking about the population that you're concerned about being uninsured. If we could do something to limit to where they're not buying sugar and stuff that's just perpetuating and starting these diseases early on in these children, if we could just say, look, meat, bread, vegetable, fruit or whatever, is there any talk, did you hear any talk of the USDA or anybody that's willing to address the fact that we're feeding the problem by not regulating what can be purchased with these transfer dollars to our some of our poorest and, less insured or lack of insured folks, as far as us having an impact, just saying that this is, what can be purchased with it, that it's not going to at least not start diabetes in a 4 or 5-year-old.
Yes, ma'am. You're singing my song. I have the same concerns, and I know what we're able to do in the WIC program, because the WIC program is with us, also a USDA program. And a huge part of the WIC program is nutritional education. And so that to get WIC benefits, you have to go through the nutritional education component. And WIC does a better job of limiting and promoting healthier food. Unfortunately, healthier food costs more. And so it burns through their benefits faster, which I understand, but it is frustrating, for SNAP benefits to buy a lot of high calorie, low nutritional value food. Right. I understand the challenge, and it also is an issue with our food deserts, the areas of the state without supermarkets where it's harder to access that, but things are improving.
I just think the USDA could do better with surplus
Yes, ma'am.
foods and things that they do to try to integrate into that program. Anybody else have any questions for Dr. Edney? Well, we thank you, sir, and we will be getting back with you specifically on some of these issues that Senator Hobson discussed with you. And it sounds like you're making progress.
We're trying. Thank you, Madam Chairman. Thank you, committee members. I appreciate your time.
I want to say one other thing. You were talking about the high-risk pregnancies. I would like to begin to address the standard of care at our freestanding emergency rooms or any of our, walk-in emergency rooms, to have some type of standard of care for just general obstetrics, because the things that I hear from people that I know that are telling me things that actually went on when they went to the emergency room. It shouldn't be happening. So I think if we could just get a uniform standard of care, if a woman comes in, anywhere near 20 to 25 weeks pregnant or whatever, we don't want somebody to go septic. There's so much misinformation that's been spread out there. There's nothing in the law that says a woman can't be treated for whatever condition she has to preserve her life and her health. So I think if we could start addressing that too, that would help a whole lot. We hadn't had the problems that some of these other states have had in the lawsuits and things, because I think our people have better sense that are providing care, but we don't want it to ever go there.
Yes, ma'am. That actually is one of the recommendations from this year's Maternal Mortality Review Committee report that the Board of Health is taken seriously.
Thank you, Dr. Edney.
Thank you.
Senator Hobson had to step out, but we'll go ahead and let y'all get started whenever you get settled.
Good afternoon. Thank you for having me today to present our FY26 budget request. And you have two handouts. One is a few slides I'm going to walk through, and then a one-page just front and back overview of the request. So I'd like to start just by give you a brief overview of what the Department of Mental Health is responsible for, because that plays into multiple components within the budget request. So our agency is responsible for the administration and monitoring of more than 600 grants for adults, children and youth, and adolescents with serious mental illness, substance use disorders, and intellectual and developmental disabilities. We certify and we monitor 128 providers across the state. And on any given day at our state hospitals, there's about 900 people receiving 24/7 services through the different services that are offered at the state hospital, not only acute psych. And then on any given day, there is about 1,250 people who are receiving services at the IDD regional programs in the community homes. Again, 24/7 services that are provided across the state. We have 2,800 people on the IDD waiver, and then we'll talk a little more about that within the budget request, and another 1,100 who are receiving services through the 1915I. And then we also credential 3,500 staff that work throughout the state's mental health system. And they work throughout those three components that you see on that first slide. Mississippi's mental health system is comprised of three components. It's the state-operated programs that the Department of Mental Health directly operates, and then regional community mental health centers. As you know, there's 11 of those that are part of county government, but we do certify and monitor them. And then other nonprofit and for-profit organizations that have the DMH certification. So to start off, I wanted to give you your next 4 slides are basically a behavioral health and IDD FY24 impact. state. And I wanted to highlight just a few things because this is specifically related to the funding that you provide us to provide services across the state. So you can see on that first one, it is state hospitals. And there were 672 people that were served in the substance use units at the state hospitals. We have 2 substance use units. We have the female unit with 25 beds at Mississippi State Hospital and 35 beds for males at East Mississippi State Hospital. And again, they served 672 people. All of those people received a court commitment for substance use treatment. There were 1,897 acute psychiatric admissions to the state hospitals last fiscal year, and the average length of wait in jail for state hospital admissions was 2 days in FY24, which was a 58% decrease from the previous year. Now, that's the wait once the state hospital receives the commitment order. We also saw a decrease in our overall length of wait for the state hospitals from the previous year. And I think you'll see this even more in this coming fiscal year. So there was legislation last year that changed the civil commitment process pretty drastically. And we've already seen within the first quarter data much improvement. We saw a 58% decrease in the number of people who were being admitted to the state hospital from a jail. So they're moving from the jail setting to the state hospital setting. We saw a 58% decrease after that legislation went in effect just for the first quarter. And then we saw a 63% decrease in the wait time, and we saw a 13% decrease in our state hospital admissions. And much of this is due to the stakeholders, chancery clerks, judges, law enforcement, community mental health centers, state hospitals, working together to ensure that people are receiving the appropriate level of care and that we're maximizing community services and we can have that state hospital bed available when it's needed. So we're seeing those things go in a good direction. The next one's the community-based services. You provide funding to us for grants for community mental health centers and other providers that go to a variety of these services. One in particular that I wanted to mention is there were 2,328 people who received intensive community support services. That's 3 different services. It's PACT, which are programs of assertive community treatment, the most intense. I-Court, which are intensive community outreach and recovery teams. Both of those services are for people who've had multiple admissions to a state hospital. And then intensive community support services, which can be provided to a person who maybe only had 1 admission to a state hospital. But that's just the number served. You really want to see the outcome. So out of that 2,328 that received those services, those intensive services, 8% had to be readmitted to a state hospital. And that is significant considering those people who received those services had had multiple admissions to a state hospital. So these community services that you're funding and the community mental health centers are providing, they are working. You can see there that there were 3,873 admissions to the crisis stabilization units. You fund crisis stabilization services in the state, and there was a 14% increase in the number served between those last 2 fiscal years. You also funded a pilot project and then expanded that for court liaisons. And that's a grant that's provided to the community mental health centers, and they hire a court liaison that works directly with the Chancery Clerk's office to try to divert someone from having to have a civil commitment and having state hospital level of care. And there was a 58% diversion rate with the court liaisons this past year too. So we're seeing that's all of this kind of plays hand in hand where we're seeing the decrease in the number of admissions coming from the jails and the decrease in the admissions to the hospital. The next outcome is on the intellectual and developmental disability side. So there were 690 people that were served on those state-operated IDD regional campus, and then another over 500 that were served in the community homes. The waiver we're going to talk more specific about, so I'm going to skip that at the moment. And then the 1915I, you can see there are about 1,100 people. When you look at all of the services for individuals who have intellectual and developmental disabilities, those that are provided at an institution, the regional program campus, and those that are provided in the community, 87% of the people are served in the community. We've been able to move many people from the institutions into those community services through things like the waiver. The next slide highlights 988. The legislature's been very supportive of 988, which was legislation passed in Congress for the National Suicide Prevention Lifeline to move to just a 3-digit number. You can see from FY '23 to FY '24, Mississippi had a 14% increase in the number of calls. So more people are becoming aware of 988. You call 988 and you will get a trained counselor who can help talk you through what you need or connect you to resources like a mobile crisis response team. And in our state, we have one of the highest in-state answer rates in the nation at 97%. And then local law enforcement, public safety, the legislature's been very supportive. We've got a great partnership with the Department of Public Safety and local law enforcement to make sure that all law enforcement entities have at least one trained crisis intervention team officer. And you can see some data there from this past year on how many officers have been trained and how many agencies have received training. You also see some information on naloxone. Last year, you specifically appropriated $25,000 for us to be able to purchase naloxone to distribute to individuals in the community. And then we also received federal funding for that as well. So just last fiscal year, there were 6,500 doses of naloxone distributed across the state. And then we also partner with the health department and the Attorney General's office on this as well. So that just is a brief impact of what your funding last year has been able to accomplish with the provision of services. Moving now to the next slide, which is the budget request. In general funds, we are requesting $283,092,360, or $27,458,644 more funds from the current fiscal year. And you'll see on that slide the breakdown of how that general fund increase is being requested. The first item is $6.6 million for staffing and operation of the new 81-bed forensic unit at Mississippi State Hospital. The unit will open in the spring, most likely in April, and it will have 81 maximum security beds for forensic services. Many times when you hear about an individual waiting in jail, a lot of times that's due to a forensic evaluation or competency restoration. So Mississippi State Hospital is the only inpatient program for competency restoration in mental health and forensic services in the state. The limited number of beds that have been available through the years has caused an increase in the number of people who are waiting, which was why we addressed that through renovation and creation of this 81-bed unit. You can see that when we have the 81-bed unit open and operational, the current bed capacity will be 121 because that's maximum security. And we also have some medium security beds that we've worked to create at Mississippi State Hospital in another building as well that are already operational. This is a significant staffing increase that's required to operate this unit. And that's why this is included in our budget request. But it's important for the state for two reasons. One, forensic services keeps Mississippi communities safe. Providing inpatient treatment to people who have been incompetent defendants so they can stand trial, moving incompetent pretrial defendants out of jail to a location where they can be more safely treated and then restored to competency, and then housing and supervising very high-risk, non-restorable defendants in forensic services, and not restorable defendants with violent charges such as murder, rape, arson. That all occurs with forensic services at Mississippi State Hospital. This also will help prevent future litigation for the state. We have high-risk pretrial individuals, and if defendants wait too long for competency restoration treatment, as you've seen in other states, there can be litigation. There can be litigation for the Department of Mental Health, and there can be litigation for sheriffs and local counties as well. So this is one of the reasons that we're investing in forensic services, and we need that staffing fund, those staffing funds to be able to have it operational. The next portion of the budget request, or the increase in forensic services, is for the IDDD home and community-based waiver. We have a request for $2.9 million to enroll 200 people off of the planning list and onto the waiver services. We've also requested $5.7 million for rate increases that the Division of Medicaid will be implementing in July of 2025, which are much needed for the providers. DMH, is the operating agency for the waiver. So the Medicaid match portion is appropriated to DMH, and then there's federal Medicaid dollars as well. And just to give you an idea of the planning list, as of July 1st, there were 2,868 people receiving waiver services and 2,521 on the planning list. Now, all of those individuals would not necessarily need services today if they were offered to them. Some are receiving services through another waiver, or maybe in a nursing home, or even one of our regional programs. But there's many people who do. So we're trying to consistently move a portion of individuals from the planning list to the services. So that's the 200 people that we are requesting that funding for. The next portion of the budget request is related to operational shortfalls at the DMH state operated program. And this is $4.8 million. At our IDD regional programs across the state, after a significant focus the last several years on deinstitutionalization and moving people to the community, the clients that we continue to serve 24/7 on these campuses have higher needs, and they are aging. I want to give you a few examples of this. 10 years ago, 48% of the clients were above the age of 45. Now 62.3% are. There's been a 40% increase in the number of clients that we're serving that are over the age of 66. The number of severe and profound intellectual functioning levels has increased from 72% to 82.4%. We are serving individuals who have a very high need level of care at our regional programs. We're serving 11% more with autism and 9% more who are non-mobile. So due to these significant needs and these changes in the clients that we're serving, there's many times that a client has to have one-on-one in order to keep them safe. We're also seeing more significant needs at our state hospitals with more one-on-one with psychiatric admissions as well, and individuals coming in with dual diagnosed psychiatric and drug addiction or substance use disorder. So due to staffing difficulties and addressing salary inequities, and to become more competitive, we've increased salaries and wages over the last 3 years with the support of the State Personnel Board and you. Due to inflation, we've also seen an increase in utilities, fuel cost, especially at our IDD programs, contract medical services, dietary food services. Just like you've seen an increase in your householding cost, we're seeing an increase at our programs that are providing this 24/7 care. The next category is on salary adjustment. It's a $6.6 million request, and this is for hiring and salary adjustments, which include shift differential. The support care professionals and nursing staff, if they are willing to work a B shift or a C shift, then this gives them shift diff pay, an increase in pay if they're willing to work those night shifts. It also includes in-range salary adjustments to help become in alignment with SPB, and includes service longevity, educational benchmarks, and filling of vacant positions. We are trying to have a very coordinated effort during the COVID pandemic, when recruitment and retention is still difficult. But during the COVID pandemic, it was to levels that I don't think anybody could have predicted. And we had to hire many individuals in contract positions. And we're trying to make an effort to move away from those contract positions, because they cost more, back into some of the state PINs and some of the state positions. So we're going to work to try to fill some of those vacant positions from contracts over the next year. With support from the State Personnel Board and the Mississippi Legislature, we were able to adjust all of our salaries to the minimum with the SEC Squared project. However, 93% of Department of Mental Health employees are still below market. They're at minimum. Minimum was what we funded in the SEC Squared. But market is the more competitive rate, especially with healthcare. So we're trying each year to move a little bit closer to market when possible and when we have that funding to where we can be a little more competitive. It's healthcare. You can't provide healthcare without staff. And with 24/7 programs, you have to have staff around the clock to provide this work, and it's difficult work. For many of our positions, though, just to put this in perspective, we're competing with UMMC and the VA and other healthcare providers whose salaries are just often higher. In many of our positions, we're competing with industry jobs such as fast food and factories. For example, in September, I read an article that Aldi, the grocery store, they are across the board. They were going to increase their start pay for any employee working in the grocery store to $18 an hour and warehouse workers to $23 an hour. Our support care professionals, starting at support care professional 1, is about $11 an hour. Support care professional 3, that's about $14.50 an hour. And that's our largest category of support care professionals. So it's often that's what leads us to have to recruit in contract positions where they're $15, $16, $17 an hour. When I came into this job 4 years ago, I set a goal that we would have our support care professionals at an average of $30,000 by 2025, because that's still a struggling livable wage. We're almost there. We're at about $29,000 now. We have made significant efforts to increase these salaries because of your help and the State Personnel Board, but we have to keep doing that as well because they're still not competitive to a lot of other jobs that they can go work at in their community. And we cannot provide health care without our staff. The last category that you'll see is $780,000. This is to add a child and adolescent specialist to each one of the mobile crisis teams. So you fund a mobile crisis team in every region through a grant provided by DMH to the community mental health centers. And this was really a result of conversations with Child Protective Services and with youth court judges on the need of having someone that can respond, mobile crisis response team, but that has specific focus on children and youth. Those teams had 7,800 calls last year and about 2,700 face-to-face visits. So that's that last portion of the request. And then you can see we're also requesting the restoration of the general funds that were reduced under the Joint Legislative Budget Committee recommendation of the $5.9 million. The next few slides we can go through very quickly. I just want to show you there's a lot of questions often on institutional care spending versus community spending. So that next slide breaks that down for you. You can see back in FY12, so 12 years ago, through our agency, 57% of the funding was going to institutions and 43% to community. In FY24, 61% is going to the community and 39% is going towards institutions. So there's been a significant change in the way that the funding is distributed. That next slide just gives you kind of a pie chart showing you how the FY25 budget is to be funded and how that breaks down in general funds. The next is the ARPA funding. So Senate Bill 2865 provided $51 million to the Department of Mental Health through FY27. And you can see a breakdown of how that funding is going to be used or is being used through additional CSU beds, 988 support, mobile crisis team support, law enforcement training and the court liaisons, peer respite sites, intensive community support services and adolescent offender programs for children and youth, IDD crisis services and supports, and then also to begin 7-day admissions at our state hospitals. I'll let you know we started that July 1st, 7-day admissions instead of 5-day admissions, and we had 13 weekend admissions over the last 6 months. The next slide just gives you a visual of the staffing decrease, and while we do have these staffing needs, you can see there's 4,770 employees as of December 31st. That's a slight increase from where we were, but we're still down about 1,000 employees from pre-COVID staffing numbers. So this is also one of the reasons we're focusing on moving away from contracts as much as possible. And then the last slide is just some future goals with the funding that you provide that we want to address. You can see that very first one is to ensure timely access to a state hospital bed by maximizing the utilization of services and supports in local communities. I want a person to have access to a state hospital bed the day that they need access to a state hospital bed. And we have worked on getting that time down. There's also a lot of times issues with transportation. We will have a state hospital bed and we will call and tell someone we have a state hospital bed, but they can't transport that day or the transport's the next day because transportation falls to local law enforcement. So working through some of those problems in the future is going to be necessary as well. Expanding access to addiction treatment services, expanding the home and community-based services to prevent institutionalization for people with IDD. Getting that forensic unit open, that 81-bed forensic unit open is a goal. And then the last one is one we recently made some progress on, and that is to create a statewide online resource for access to services for behavioral health and IDD. It's often difficult to navigate the system, and the system's very large. We have a great app called Mental Health Mississippi that helps you connect to resources on the mental health side, but there's also substance use disorders and intellectual and developmental disabilities as well. So this would help create an online resource for all of those services to where people could go to one location to be able to find the help that they need. So that concludes my presentation, and any questions?
Any questions from the subcommittee for Ms. Bailey? Senator Polk.
Thank you, Chairman. You know, we gave a lot of ARPA funds, as you mentioned, and one of the things was to try to get the federal government more on our side. And by doing the things that they've asked us to do that we couldn't afford. Are we making progress there?
I would say yes, sir, because a lot of the funds are being used for community services. So, for example, with the federal government, with the Substance Abuse and Mental Health Services Administration, one of the things that you hear from SAMHSA all the time is your crisis continuum of care. You need a full crisis continuum of care in your state. Well, part of those ARPA fundings are supporting the 988 call centers, which is on that continuum of care. It's supporting mobile crisis response, which is on that continuum of care, and it was increasing crisis stabilization beds. That's just one example where the funding is being used and it's directly aligned with the federal government with SAMHSA.
Did you return recently any ARPA funds to the state?
Return I know we put forward a proposal of what we thought we could spend before that deadline came, and then we were reappropriated the 51 million.
Okay, so how much did you not use that we had assumed you would?
I think it's about 30 million.
Really?
Probably so.
Actually, it was originally 86 million, went to 51, and there was also about 18 million, which part of was used. So really it's about 40 or 50 in total, but they were
Wow.
two different projects.
That is surprising. That's a lot of money left on the table. Of course, we spent it as a state, but it was not spent by you, by mental health. Any particular reason?
Well, many of the projects that we put forward were related to staffing. So there were projects that would start up like the crisis stabilization beds, mobile crisis, where it took a little time to get it up and going. So that first year, there was not as much spent. They were recruiting and trying to hire staff for the services and get them up and going. So that was part of it as well. Our projects weren't so much a brick and mortar or a water sewer system. It was direct services where you had to hire the personnel to. That was part.
What about equipment? Was there any equipment that you could have purchased that we didn't? computers, things like that?
So there was the request that the Department of Mental Health made, and then there was also a request that came through the Office of the Coordinator for electronic health records for the community mental health centers. That was one of the things that was discussed, and that was not able to be accomplished. We went through the process with ITS to hire a consultant who could review the systems, because we needed to know there's multiple systems that the community mental health centers use. So we needed to know what a recommendation was. We went through that process, hired that consultant, and he produced a report. We got the report in April of this year, and the session was wrapping up, and we could not be guaranteed that we could get a bid completely through the process to have an electronic health record system by the time it had to be obligated, which was by December.
Okay, so April of 24. Okay. All right, thank you. Thank you, Chairman.
Of course, we will do the best that we can for you, and we do see progress. I've been here this is my 14th year, and I think I've seen more progress in mental health and the Department of Health, both of these two subcommittees that I deal with. Nothing to do with me, it's to deal with the people that are running these agencies. But I think I've seen more progress in the last few years than I have in the whole time I've been here, so I do appreciate it, because the things that people complain about are the things that are finally getting done. And that's some of the same things that the federal government has leaned on us to do. So I know that Rome wasn't built in a day, but I have seen a lot of progress, and I know that y'all are trying to use the dollars that we give you in the best way that you can. And sometimes it's just not humanly possible to do everything that we want to do. But we will continue to try to work with you and make things better for everybody across the state. Wendy, do you have any questions for Corbin, or anything y'all need to address before y'all leave?
I think so.
Okay,
Thank you.
thank you.